Case 4. 10-year-old Asian girl presents with 10 days of fever and malaise and 5 days painful stiff ankle, right wrist and left knee. 2 weeks earlier she had a sore throat, mild upper respiratory tract infection treated with antibiotics. On admission she is febrile, 39 degrees Celsius, with a swollen, painful joint and soft pericardial rub, but no rash, lymphadenopathy, or hepatosplenomegaly. Key investigation: hemoglobin 10 gram, MCV 80, WBC 12, neutrophilic, platelets 400, ESR 115, CRB 80, urea electrolyte normal, bilirubin AST mildly raised, AST 65, autoantibodies latex screen negative, ASO titer 500 international unit, acutely 800 convalescent, blood urine throat culture negative, hepatitis A IgM negative, hepatitis B surface antigen negative, joint aspirate inflammatory 3000 neutrophils per mil, sterile, chest x-ray and joint x-ray normal, ECG sinus rhythm BR normal, echocardiogram mild mitral regurg, small pericardial effusion. What is the most likely diagnosis? This is acute rheumatic fever with carditis, mild mitral regurg, pericarditis, and migratory polyarteritis following group A beta hemolytic streptococcal pharyngitis. She meet revised Jones criteria, Docket Jones criteria, major criteria: migratory polyarteritis, carditis, mitral regurg plus pericardial rub effusion. Minor criteria of fever: raised ESR, CRB, mild anemia, evidence of recent streptococcal infection, raising ASO titer, and preceding sore throat. Previous hepatitis A in Pakistan is the resolved, stable antibody titer arguing against acute hepatitis. Now, what treatment would you give? Anti-inflammatory therapy for arthritis and carditis, high dose aspirin, acetyl salicylic acid, dose for pediatrics 75 to 100 milligram per kg per day orally in 4 to 5 divided doses, maximum around 4 gram per day in adolescents, aiming for therapeutic salicylate level. Continue high dose until arthritis and fever resolve, usually 2 to 3 weeks, then taper over several weeks. If moderate severe carditis or heart failure develop, not yet here, guideline often recommend Brisolone 1 to 2 milligram per kg per day orally, maximum 60 milligram per day, then taper over 2 to 3 weeks with aspirin overlapped and continued as steroid as weaned. Eradication of streptococcal infection, even if throat swab is negative, give a full eradication course. Benzazine penicillin G, single dose 600,000 units IM, if less than 27 kg, or 1.2 million units IM if more than 27 kg. Alternatively, if IM not feasible, phenoxymethyl penicillin V, 250 milligram orally, 2 to 3 times daily for 10 days. If penicillin allergic, azithromycin 10 milligram per kg once daily for 3 to 5 days, or erythromycin 40 milligram per kg per day in 2 to 4 divided doses for 10 days. Secondary prophylaxis to prevent recurrence: because she has carditis with valvular involvement. Long-term prophylaxis is essential. Secondary prophylaxis for first line benzazine penicillin G IM every 4 weeks, 300,000 unit and 1.2 million every 4 weeks. Duration at least until age 21 or for 10 years after the last episode, whichever is longer. Many guidelines recommend even longer in persistent valvular disease. If IM not acceptable, penicillin V 250 mg orally twice daily as continuous prophylaxis, but IM is preferred for reliability. Adult continuation if she later works with or around young children or in high risk setting, prophylaxis can be continued beyond age 21. Supportive care, bed rest during the acute phase with gradual mobilization guided by resolution of carditis and inflammatory markers. Physiotherapy to maintain joint mobility once pain permits. And monitor vital sign, heart failure signs, and repeat echo to follow valve lesion and pericardial effusion. ESR, CRB, AST as markers of acute activity. AST may rise with rheumatic myocarditis and will fall at the attack resolve. Discussion and extra point provided the dramatic response of the arthritis to aspirin is typical of rheumatic fever. Major Jones criteria: polyarthritis, carditis, erythema marginatum, subcutaneous nodule, Sydenham chorea. Minor criteria: previous rheumatic fever, fever, arthralgia, raised ESR, CRB, prolonged PR interval. Evidence of recent group A strep throat culture, raising ASO or anti-DNase B titers, or history of scarlet fever. Differential diagnosis include still disease, systemic juvenile rheumatoid arthritis, and viral or rubella arthritis, active hepatitis, active infective endocarditis, sickle cell disease with osteoarticular crisis, septic or gonococcal arthritis, malignancy, example for leukemia.